Good afternoon, everyone. From Department of Surgery, we are presenting today very interesting case. That is something was lost and we fortunate enough to find it. Our junior resident, Dr. Rishikesh, will present case, and our MCS senior resident, Dr. Prasant, will discuss the review of literature. We have our co-contributor from Department of Radiology, Dr. Ankur and team, and from the Pathology, Dr. Adarsh and team. Thank you. I request to Dr. Rishikesh, please continue.
Here is a 44-year-old male with BMI of 39.1. He's from Gorakhpur, Uttar Pradesh. He's businessman by occupation. He came to us with recurrent discharging sinus from right lumbar region associated with pain and intermittent fever for 4 years. He underwent laparoscopic cholecystectomy for symptomatic gallstone disease, and postoperative period was uneventful in the year of 2015, that is 5 years back. He was apparently well for 1 year after that. After 1 year, he developed swelling associated with pus discharge. The swelling was insidious in onset and gradually progressive. It was present in right upper back and was associated with discharge that was occurring after the rupture of swelling. Then there was subsequent swelling and discharge, which were intermittent in nature, about 2 to 3 ml per day, and seropurulent in nature. The swelling was associated with pain, which was dull aching, present in the upper right back, and it was lasting for about 6 to 8 hours, and it subsided after the rupture of the swelling. The pain had no radiation to any other region and was relieved with oral analgesic. It was also associated with fever, which was high-grade, intermittent in nature, and it was associated with chills, and the fever used to subside on the rupture of swellings. It was also relieved with oral antipyretics. In 2016, when the patient was initially symptomatic, he consulted a private hospital where it was diagnosed as an abscess, and incision and drainage was done, which provided temporary relief of symptoms. There was recurrence of discharge with swelling at the same site, for which the patient underwent series of imaging. First of which was the CECT abdomen, which showed a collection of about 5 into 4 centimeter in the right lumbar region, involving paraspinal muscle extending to the superior border of D12 up to the inferior border of L1 vertebral body. So for this, he underwent repeat IND twice in the same year. During one of these drainage procedures, the pus culture came out to be positive for Klebsiella pneumonia, and appropriate antibiotics were given. The gene expert cultures for TB and PCR were all negative, and cytology was done, which showed spindle cells. Even after this, the symptoms, he was not symptomatically better, so it was empirical anti-tubercular drugs were started, and he completed the full course. The course of ATT did not relieve the symptoms, so he underwent multiple imaging in the same year. He underwent CT sinogram and 2 MRIs, which showed now a sinus tract in the right paraspinal region, extending from skin to subdiaphragmatic space, in addition to the previous collection. So after all the multiple imagings and the drainage procedures, he was still not symptomatically relieved. So he underwent a diagnostic sinoscopy with exploration and excision of sinus tract along with the 12th rib, and he was symptomatically better for 4 months. And after 4 months, he had again recurrence of discharge from the same site. So after 4 years after laparoscopic cholecystectomy, when he was still symptomatic, the imaging was repeated, which showed a well circumscribed thick walled tract showing extension from skin, now extending into the retroperitoneal space and anteriorly into the parenchyma of segment 6 of right lobe of liver. So he underwent, under general anesthesia, he underwent diagnostic laparoscopy, curettage of fistulous tract, and laser ablation of the tract. The histopathology showed inflammatory tissues without any granulomas. Even the fungal cultures were negative. So, to summarize this long and tedious history, he underwent laparoscopic cholecystectomy in 2015. He became symptomatic with chronic discharging sinus in 2016. Multiple incision drainage procedures were done. Appropriate antibiotics and anti-tubercular drugs were given. Even multiple imagings were done, and he initially underwent diagnostic sinoscopy with exploration and excision of sinus tract along with the 12th rib. And also in 2019, he underwent diagnostic laparoscopy with curettage of fistulous tract and laser ablation of the tract. But still, he was not symptomatically better. So he presented to us in AIIMS. He is known case of diabetes mellitus, type 2 diabetes mellitus for 4 years on oral hypoglycemic drugs, and his personal and family history were not significant. On examination, he is a morbidly obese male. He was alert, conscious, and oriented to time, place, and person. There was no pallor, icterus, lymphadenopathy, or edema. His vitals were stable. On systemic examination, the cardiovascular system, the respiratory system, and the central nervous system were within normal limits. On abdominal examination, anteriorly, there were scars of previous surgery, previous laparoscopic surgery, that were laparoscopic cholecystectomy, along with the diagnostic laparoscopy done outside. And there was, as you can see in the image, there was a horizontal scar in the right upper back with a sinus tract at the center of the scar with pus discharge. And there was no underlying mass and no hepatosplenomegaly. So we came up to a clinical diagnosis of non-healing sinus with pus discharge. So what might be the cause of this? It might have been infective cause, it might be a malignant cause, or a foreign body, or a enterocutaneous or a biliary fistula. The infective causes, chronic infective causes, were ruled out by conducting TB tests like TB cultures and PCR, and fungal cultures which were negative. Malignancy was ruled out when the biopsy had showed no evidence of neoplasia, and enterocutaneous or biliary fistula were ruled out as there was no bile leak. So we narrowed it down to foreign body, and we reviewed the previous surgical history, and the foreign body might have been a gossipy bioma, which was retained sponge or a mop, and or a spilled stones due to the previous laparoscopic cholecystectomy. So we made a plan to further investigate the patient, and I would like to call upon Dr. Tani for imaging details.
We have representative images of the limited imaging available to us. A CCT abdomen was done for this patient on 10th April in 2019. This is the contrast enhanced axial sections of the CT, and we can appreciate that there's an irregular, heterogeneously enhancing soft tissue lesion which is seen in the right posterolateral abdominal wall. In the deep surfaces, it is reaching up to the segment 6 of liver, and superficially across the subcutaneous plane, it is reaching up to the skin surface. Also, we can appreciate a calcific focus which is seen within this heterogeneous soft tissue, which may represent post-operative changes, or it may be a foreign body. So based on the CCT, we can suggest the possibility of an inflammatory etiology. No frank abscess formation is seen within these images. So to further characterize it, the patient underwent a CMRI, which was done on 15th January 2020. These are the axial sequential axial T2 weighted images. we can see that there is presence of an irregular collection around 1.4 to 1.3 centimeter, which is seen along the segment 6 of liver and is also reaching up to the perinephric space along the right kidney. We can see there is a well-defined tract which is seen reaching from the deep surface up to the superficial skin surface. Also, we can see presence of a T2 hypointense content within. This is a sagittal image which is showing the fistulous tract in its entire extent, reaching from the segment 6 with surrounding heterogeneous collection and inflammation with well-defined walls of the fistulous tract. We can see there is a well-defined round discrete T2 hypointense content within, which may suggest a retained gallstone. Also, this is a coronal image of contrast enhanced MR, and we can see enhancement along the walls of the fistulous tract. These are the corresponding T1 weighted images and T2 weighted images, and we can see that there is hyper intensity on T1 weighted images within this this discrete gallstone, which we can see. So, and these are the multiplanar images which is showing the same. So, based on this, we can suggest a possibility of retained gallstones leading to recurrent collections and fistula formation. So, drop gallstones is diagnostically challenging because the time to presentation can vary from months to years. So, temporal remoteness, also spatial remoteness. These drop gallstones can migrate anywhere within the peritoneum, reach up to the pelvis or pleura. However, using one of these three, ultrasound, CT or MR, we can pick up almost all the drop gallstones. These images also show presence of a gallstone with surrounding collection, and this is a partially calcified stone which is picked on the CT image. The role of imaging modalities, if we have a well-defined opening for a fistula externally, we can inject contrast through it and look at the filling defects within. Also, ultrasound will allow us for better characterization of superficial collections and inflammation. Ultrasound guided saline installation into the fistulous tract has also been described, which allows these calculi to appear as rolling hypoechoic calculi with shadowing. Also, MR allows us to characterize these calculi based on the T1, T2 signals. However, air and calcification remain close mimics. The CT has limited role because most of the gallstones are radiolucent, and an additional non-contrast CT is advised in case of clinical suspicion. This is diagnostically challenging because of the multiple mimics we have, like a calcified peritoneal metastasis or peritoneal loose bodies, as well as sometimes they can be mesenteric or peritoneal lymph nodes, and their migration may lead to suggestion of a primary ovarian tumor, or even sometimes they can be diagnosed because of this repeated subcutaneous inflammation as a soft tissue sarcoma. Thank you.
So after reviewing the previous imaging and doing a fresh imaging here at AIIMS, we came to a final diagnosis of non-healing discharging sinus due to spilled gallstone, and plan was made to explore the patient. He underwent exploratory laparotomy with excision of sinus tract with removal of spilled gallstones on 17 January 2020. Methylene blue dye was injected through the sinus tract. Right subcostal skin incision was given. Dense adhesions were noted between the liver and lateral parietal wall when we entered the abdomen. The fibrosed sinus tract noted extending to the segment 6 of liver, and the methylene blue stained tract was identified. After adhesiolisis, the multiple small stones were noted along the tract and were lurking behind the liver. All the visualized stones were retrieved after thorough exploration. Entire sinus tract along with the surrounding fibrous tissue was excised and which was communicating with the retroperitoneum. Thorough lavage was done. These are the gallstones which were retrieved from the abdomen, and also the sinus tract with the surrounding fibrous tissue. The patient had an uneventful postoperative period and sinus tract was left open. He was discharged on post-op day 10 He was on regular follow-up with us, and on 9th month of follow-up, the wound had completely healed, and patient was doing well, and there was no recurrence of the initial symptoms. Now I would call upon Dr. Sanjay from Pathology to discuss about the histopathology.
So grossly we received multiple pieces of irregular soft tissue which had a skin lining in one surface, and on cutting open we saw a sinus tract which was measuring for a length of 2.2 centimeter, and this is a lower image of the sinus tract. Here you can see the sinus is almost lined by fibrocollagenous tissue with mild inflammation, and this is a hypo picture of the granulation tissue which was found in the center of the picture and also lining the sinus tract. And here you can see chronic inflammation along with many vascular proliferation, which is indicative of inflammatory granulation issue. Apart from this, we didn't find any granulomas or dysplasia or something. Now, thank you. Now, Dr. Prashant will continue with the review of literature.
Good afternoon. We'll see what additional information a review of literature offered. Laparoscopic cholecystectomy is one of the commonly performed general surgical procedure, and during surgery, an accidental perforation of the gallbladder can occur, and it might lead to spillage of bile and gallstones. The incidence reported is highly variable from 6 to 40%, and the incidence of stones lost into the peritoneal cavity not being retrieved is reported to as close to around 2%. And there are multiple factors that are described which might lead to a gallbladder perforation and spillage of bile and even stones. These could be an acutely inflamed gallbladder, as seen in acute or chronic cholecystitis, or dense adhesions of the gallbladder to surrounding structures like the duodenum or the colon. When the gallbladder is distended, when there is a mucocele of the gallbladder, or when there is acute inflammation, this might lead to perforation of the gallbladder. And when the gallbladder is being dissected from the liver bed, there might be a slippage of the cystic duct clip. This might lead to slippage of the stones and bile within the gallbladder. And while the specimen is being extracted through the ports, this clips might slip and the gallbladder might perforate also. This might also lead to perforation of the gallbladder and stone slippage. An inexperienced surgeon during his early curve of learning might also lead to increased incidence of gallbladder perforation and hence spillage. We'll see what happens to a spill stone within the peritoneal cavity. We have to keep in mind that most of these stones are silent, and more than 90% of these stones don't present at all. And when they do present, they might present in varied presentations. For example, in a 34-year-old male, he presented with a colocutaneous fistula. The stone has eroded into the colon and presented with a colocutaneous fistula. Rarely, it can erode into the pleura and cause lung abscess, hemoptysis. And intra-abdominal multiple abscesses are described: pelvic abscesses, subphrenic abscesses, and very rarely there is a report of hematuria. The stone actually eroded into the bladder, and patient presented with hematuria. Multiple infective complications like chest wall fistulae, empyema, pleural effusion, everything is described. Based on the site of involvement, it can be divided as local, distant, or systemic. Local when the stones are near the operated site in the subhepatic region or near the liver. Distant when the stone migrates to the pelvis or migrates into the thorax, causes symptoms there. Systemic when it presents with systemic illness like fever. And based on the pathophysiology of how a stone causes symptoms, it could be infective. Because gallstones are basically found on the nidus of infection, and they are basically infective by nature. Another possibility is that gallstones are stones and because mechanical symptoms. So this is a type of classification by which we can classify how they become symptomatic. So local complications may be in the form of abscess, sinus, or fistula. Abscesses are most commonly seen in the abdomen. When there is a gallstone spillage and it is embedded in the wall with the port side, it can present as an abdominal wall abscess. Intra-abdominally, the abscess can be formed within the peritoneal cavity, or it might seep into the retroperitoneal space and form retroperitoneal abscess as well. It can form sinuses to the skin, most commonly in the port side, and also it can go into the flank on most commonly on the right side, as it was reported in our case. Can also fistulate with internal organs like urinary bladder or colon, as mentioned in our case reports. Intra-abdominal could be intraperitoneal or retroperitoneal. The most common presentation of an intraperitoneal abscess would be in the subhepatic region, that is the most common location, and the retrohepatic, that was in our case. Other locations described as subphrenic, intraperitoneal, other peritoneal would be pelvic abscess or paracolic abscess. And the distant would be involvement of the thorax or the pelvis. Thoracic symptoms could be in the form of pneumonia. It could present as empyema, and rarely a report of stone expectoration, cholelithotysis, that is, expectoration of gallstone is also reported. Other organ systems involved could be urinary or intestinal. Now coming to the systemic manifestation, patient might present with fever of unknown origin. We might not even recognize it if we miss out the history of laparoscopic cholecystectomy. You might also see bacteremia, and patient might present with peritonitis. This is more likely in the immediate postoperative period. The infective complications, as mentioned earlier, it could be most common would be an abscess and delayed presentation in the form of chronic inflammatory sinuses and fistulae. And the mechanical cause caused by the stone itself, it could lead to intestinal obstruction by the stone migrates into the intestine. It can stay within the subhepatic region and cause obstructive jaundice, causing obstruction in the extrahepatic biliary tree. And very rarely a case of incarcerated hernia is also reported. The stone has migrated into the hernial sac, causing irreducibility and incarcerated hernia. So coming to how to diagnose this condition, it's very difficult to diagnose a spilled gallstone. It is to be noted that a patient's complete history has to be taken, and a history of cholecystectomy should not be missed, and we'll have to have a high index of suspicion. And the presentation, as we have seen, is highly varied, and we should keep in mind that the symptoms may not be localized to the right upper quadrant. And coming to the imaging choices, we have to combine imaging with a high clinical index of suspicion. In CT, we can see collections and only radiopaque calcified stones. MRI can be investigation of choice, but it can be used along with other investigations also. MRI is good because it has having better soft tissue delineation. It can better delineate fistulous tract, and stones are T2 hypo intense and T1 hypo or iso intense. You can also combine a sinogram to describe the sinus tract, how it is extending, and it can be done with X-ray, and CT will offer better resolution and spatial resolution. This is an image of a CT showing a perihepatic collection with a stone in situ. This is a series of CT images showing a calcified stone near the omentum, and there is a perihepatic stone. Patient was asymptomatic during this period. This was a 60-year-old gentleman who had no symptoms on 3 months of follow-up, and patient on the 6th month had an abdominal pain, and on evaluation was found to have a spilled stone and a perihepatic abscess. This is a series of CT images showing a preoperative CT film showing calcified gallstones within the gallbladder. After 6 months, this man presented with abdominal port site discharge. This was found to be a spilled stones embedded in the port site. This is also a stone. MRI is also useful, and you can find that it's T2 hypointense. It's another MRI showing a collection with a T2 hypointense stone. Sinogram is also useful. A patient presenting with a sinus in the right lumbar region was sinus was visualized with a contrast installation, and the tract was seen extending up to the subhepatic region. But we could not find any filling defects, implying that we could not see any stones, and there was a collection in the paracolic gut as well. And coming to the entity, how to avoid these spilled stones. This is a scenario in which the dictum prevention is better than cure is very much important. We can do it by careful dissection of the gallbladder. We can try to avoid perforating the gallbladder and hence the spillage. And if we encounter a tense gallbladder, we can always try to decompress it before trying to dissect it. And we can use a specimen bag. We can use a commercially available ones like this endo bag, or we can use makeshift bags by using gloves or plastic sterile bags to prevent spillage and contamination of port sites. However, we try, spillage might occur. If it occurs, the idea is to remove all the spilled stones, and we should not wait till the surgery is over. And we should do as soon as the spillage has occurred, and we should remove it as soon as possible. And you can use it in combination with retrieval bags to remove the perforated gallbladder along with the stones. And we should always keep in mind to irrigate the peritoneal cavity to decrease the contamination. And when these patients present as a symptomatic spilled gallstone, when they are symptomatic and they have abscesses, we have to keep in mind that there is no role for medical management. The treatment is always surgical. You have to go there and remove the stones, and we have to do proper imaging and plan the definitive management. The treatment is surgical exploration, excise the entire fistulous tract, remove all the stones, and ensure that no other stones are retained in the abdominal cavity. I would like to conclude with the following take-home messages. Intraoperatively, we will try to dissect the gallbladder carefully and try to minimize the gallbladder incidence of gallbladder perforation and hence the spillage, and retrieve all stones when spillage occurs. And we should have always try to document that spillage has occurred in the medical records, so that when the patient might present in the future with any complaint, this will be kept in mind. And we have to keep in mind that most spill stones are silent. They might not present at all. 90% of spill stones, they don't present at all. And when people present, we'll have to keep, it will be a diagnostic challenge. We'll have to have a high index of suspicion. And when they do present, surgery is the only treatment. Thank you.
Thank you all presenter, and this is very interesting case presented by us, and now this case is open for discussion.
The prevention is better than cure. So, like most of the times, I think that the government doctors spills the stones, the time when we are extracting the stone from the so let's be very careful when it's converted.
What is the reason for rashes formation, sir? Because of infection or?
Yeah, see, all gallstones are gallstones with an organism embedded inside. That's what Moynihan said. Majority the gallstones, when you do a culture from them, they will not. That is the reason why the gallstones can result in toxicity. So the most important thing again is when one is first whether the surgery is indicated or not. See, whenever you do an indicated surgery, you see the problem. And secondly, as we have do slowly, do carefully, avoid any untoward things which happen. But if it happens, then act quickly. Like, don't wait. If there is spillage of stones, don't continue to do the stop there, rescue all the stones. And again, it's not very easy to diagnose. We have gone through 4 years, so many. The other one even later ablation. So common things are very common. So you have to keep in mind that if something has happened and if there is something which you know can happen, then
So potential customers for such 6 to 40% was no, 6 to like that is huge.
it doesn't happen so much. Maybe about 5,000 years, but not 40.
बहुत वेरिएबल तो है किसी को तो 40 क्या होगा
What we were telling you. I think if it is possible to acute polycystic to operate, then you may get better. If you do 100 laparoscopies, 50%.
short the time surgery खत्म होने तक नहीं that's the problem मतलब बंदा super violence against
Yeah, but
you figure out on the table immediately you figure out that something is failed so this they obviously
See, do step by step very quickly. Attention to detail, right? Don't rush through an operation.
The problem is that the stones are multiple and they're small ones. Even if I get a DL, suddenly a bunch of them goes down. Then they may go in recess. They may go between the wall and take into treatment.
This is the only problem. If you don't read the message,
then it's good
generally people leave it part and cultivate. So that's the problem.
T to hypointensive which you saw in should that this is only in the imaging done here also visible on outside
People review.
showed a certain state of calcification in one area, but we were not sure because the patient had rib surgery also. So, was it a resonant calcification?
Actually, basically they went after the again. That's why the common things are very common. Somebody has undergone surgery, developed something. Somebody has started on the medication and he developed something. Always there will be a human relation.
Something is very had multiple stones coming out. So,
Because it doesn't happen often. No, even in private it doesn't happen. I don't think the accidental perforation of the organ is while being actually different. I don't think so.
so can this filled gallstones be retrieved properly laparoscopically? Does it make the case for
If
converting to
you
open?
spend enough time to do it quickly, almost all the stones can be.
Not sure only one stone.
Multiple.
See, that's what I was saying, multiple small stones that they spill. People think I will remove them later because they're too small. By the time you finish surgery, because of the insufflation and all, the stones tend to move in different directions.
Most of the stones are found in the peritoneum, not in the fat.
No, they will present, I think,
Posterior to
multiple bypass would have come and then
Remember, there was sulfuric acid. We said one stone, and we will take almost 20 stones.
Anybody else? Thank you very much.
Thank you. Thank you.